Now let's talk about some motility issues and medications that affect motility and either, well, start the process or stop the process. Let's talk about laxative and laxative medications, which will get that bowel movement process kind of going, kind of start the process. Well, we've got four major types of laxatives. We've got bulk forming, which absorb and retain water to increase the intestinal mass. We've got surfactants, which incorporate water, kind of pull water into the stool to soften it and kind of help it move along. We have osmotic laxative, or laxatives, excuse me, which retain water, attract water, pull water in to increase intestinal pressure to stimulate peristalsis, which is just a peristalsis is just a big fancy medical word to say kind of moving things along, moving that bowel movement along. We have GI motility, and then we have stimulant laxatives, which are acting directly on this intestinal mucosa, and we're increasing fluid secretion and again stimulating peristalsis. Some pretty common laxatives that you'll see out there, even off the counter. Bulk forming laxatives. Well, Metamucil is a bulk forming laxative. Keeps you regular, right? Surfactants. You'll see Colace. You'll frequently see Colace used in the hospital to deal with constipation. Same with your osmotics, right? Your Fleet's enema is an osmotic laxative, and your magnesium oxide is an osmotic laxative. And magnesium oxide, you can get that over the counter as milk of magnesia, MOM. Stimulant laxatives, you'll see Dulcolax. That's available over the counter, and you might also see that used in the hospital to treat constipation. Well, on the opposite side of things, instead of constipation where we need laxatives, we have diarrhea where we need an anti-diarrheal medication. Well, these anti-diarrheal medications, there are a number of them available over the counter. The one I really want to talk about, or the type I really want to talk about, are opioid receptor agonists. And these medications stimulate opioid receptors, just like morphine would. Not quite in the intensity that morphine would, but they are stimulating opioid receptors. If we think back to morphine, what is a common side effect, long-term side effect of morphine use is constipation. So this slows normal peristalsis by activating and by stimulating and tickling these opioid receptors. So if you see a patient taking Lomotil, if you see a patient taking Imodium, you can get Imodium off the counter, or over the counter, excuse me. So Imodium is an over-counter thing. Lomotil, you can find that over the counter. These are opioid receptor agonists. So we're going to use these in the short term, only in the short term, please, because if we abuse them, use them too long, not only are we going to prevent normal peristalsis, we are going to stop it altogether. And we're going to cause an infarction in the GI tract. And if we have a bowel infarction, that carries a much higher mortality rate and risk than does even a heart attack. So we're going to use Imodium only in the short term. But if you have a patient who might be addicted to opioids, this might be their only outlet to get a little bit of opioid receptor antagonism, or not antagonisms, agonism. So you might have a patient abusing Imodium because they are addicted to opioids. Okay, let's take a kind of a hard left turn here and talk about gout. Gout doesn't really fit kind of anywhere, so in terms of our topics, but kind of sort of fits here with the GI stuff. So let's talk about gout real quick. You've heard of gout a bunch of times. I'm sure you know people with gout. You know you've had patients with a history of gout, but what is it? Well, it's this disorder caused by either the overproduction of uric acid or the under-excretion of uric acid. So in either way, we have too much uric acid in our body, and uric acid is going to create these kind of crystals in our joints, in our kidneys, and our tissues, and that's going to create some pain. It's going to create inflammation because of these crystals. Think about these crystals just kind of digging into your joints, cutting into your joints, cutting into your kidneys and tissues. So patients are going to complain of pain, especially in their joints. And and they're going to be have this inflammation. So if you are, risk factors for gout: obesity, hypertension, and excessive alcohol use. To treat gout, it's going to be dependent on what the issue is. Do we have under excretion of uric acid? Well, then we can give Benamid. Do we have overproduction of uric acid? Well, then we can give allopurinol, which is very common. And then patients, you're definitely going to see patients on colchicine. Colchicine is used for acute gout attacks. So patient wakes up in the morning and just cannot get out of bed, cannot move. Their knees and their ankles are just locked into place and so inflamed and so painful. They can take their colchicine to treat this kind of acute attack. We can also give COX-2 inhibitors. So we can give some non-selective COX-2 inhibitors to treat gout and gout pain and this inflammation there, right? So your aspirins, your Tylenols, your ibuprofens, naproxen or Aleve, and Toradol. So if you've got a patient with a lot of gout pain on your truck, and the first line here is probably going to be Toradol for their pain. Very effective in treating gout pain. But your patient might also be prescribed a selective COX-2 inhibitor. These selective COX-2 inhibitors given for this inflammation, given for typically arthritis and gout, and most common of these is Celebrex. And if you have any questions about this stuff, please let me know.